Hi everyone, this is Shannon from LPC and we're going to start our presentation. There's a couple things I wanted to let you know about. On your screen, we can't hear you. So on your screen there should be a place for Q&A. Let's see,
on your screen it will be on the bottom.
On the bottom.
Probably at the bottom there's a little tab for Q&A, and if you have questions you can type them in directly there. Or you can also go to the chat function, which should be on the bottom of your screen, in order to chat and ask questions that way as well. Can you do us a favor, please? If you are participating, we just want to make sure the audio is clear. If you're either able to raise your hand or in the chat, just send a quick message that you can hear us, then we'll get started. Yay, awesome, thank you. Perfect. So it looks like our audio is good.
Great. Great. So I'm Shannon, and we also have some other folks here. So Tracy from LPC is here. Hello. Leslie from the Sierra Health Foundation.
Good afternoon.
And Madeline from the Sierra Health Foundation.
Hello, everyone.
So we're going to walk through this presentation with you. This is a presentation that we gave to the steering committee, and Kendra thought it would be a good idea to give it to you all, in order so we're all on the same page and we can kind of have a consistent message when we go out there and talk about this report. So you should have received the community indicator report a couple of months ago. And so we're not going to go through the whole thing, but basically my goal for today is to really kind of give you an orientation so you're going to be able to go out into the community and to your coworkers and partners and talk about the community indicator report and help you really frame the rationale for this initiative. I sort of see you all as ambassadors. So it's going to be helpful if you understand where the data is coming from and sort of how we got to the numbers that we got to. I won't bore you with too many details, but I think it's helpful just to have sort of a general orientation. And then again, like I mentioned before, I think it's going to be helpful for us all to have a consistent message. When we were pulling together these indicators and just being a part of the hub, one of the things we noticed is that we would go to different locations and we would see different numbers being used. So the number of, the disproportionality numbers, the rate of child deaths. And so what this report does is really kind of give us all sort of the same language and numbers and data in which to move forward on. And so what I'm going to do, because I can't hear you, I'm going to just talk through a couple slides, and then someone here is going to remind me to stop if I keep going. And then if you can just send a question or answer, that would be great. And then what we're going to do at the end of this is just take your questions and answer anything that comes up. So we'll have some designated time at the end, but I do want to stop periodically and just make sure I haven't lost anyone. Oops, sorry for that. Let me press the right button and the next slide. So, doing the right thing. Just slight technical difficulties here.
Hi everyone, just 1 second.
There we go.
No idea what
happened? All right. So as I mentioned, we put together the community indicator report, and I'm going to talk about three main things. The first is go over the child death data, which includes the leading causes of child death, and then how this sort of translates into the RAACD goals. We're also going to talk about the community baseline indicators. So the CILs received a neighborhood report that had some sort of similar type of data, but what it does is it looks at some of the related indicators and social determinants of health that lead to and are related to, I don't want to say lead to, but are related to the 4 causes of death. And then the third main topic is to talk about, when we talk about disproportionality, it's a big, long, fancy word, but what are we talking about? in particular when we talk about African American disproportionality. So let's see, and it went quickly. So in this slide, what we wanted to do is we wanted just to set a baseline year. A baseline year meaning before the CILs rolled out, the RAACD, the steering committee was formed, but really before there was a concerted effort on the ground to start addressing the 4 main causes of child death. Where this data comes from is important to note. It comes from the Child Death Review Team, which is a county-wide collaborative, which reviews all the child deaths within the county. And why it's important, it comes from the source. If you go and look at death data from the county, they won't have a couple of these causes of death. For example, the coroner does not categorize infant sleep-related or canned homicide. That comes from this CDRT data. So when we talk about it, child deaths and these particular types of death, that's where the data comes from. The other thing I wanted to point out is if you look, that perinatal conditions and infant sleep-related deaths, they make up 50% of the deaths. And so I think it's important when we talk about the different causes of death that they affect different, the causes are not in line with one another. There's a third thing I wanted to point out with when we talk about the data, and that is we talk about this 3-year rolling average. And what does that mean? So one of the things that we do when we look at trends, we look at numbers, is sometimes when we have really small numbers, for example, 3 or 2, you can have a really big jump in years because it's such a small number. So it can go up 50% or 30% just by a matter of a few deaths. And so what we do is we look at a rolling average. And so these numbers are actually an average of 2012, 2013, and 2014. And the reason we do that is that we can really see trends overall better, because if, say, for example, one year there's no third-party homicide, it looks like, oh, there's not a problem, but in fact, it's just the numbers go up and down. So that's where the 3-year rolling average information comes from. And then the last thing I wanted to point out, we have the four main causes of preventable death. The all other deaths, those are things like natural causes and some other types of deaths, but we're not focusing on those because those are not the causes of death outlined in the RAACD planning and strategy document. So moving right along, and you all jump in.
Ask if there's any questions.
Okay, that's right. Does anyone have any questions? That was sort of a lot of technical jargon I wanted to get through on that. So no? Okay. So let's just go. So measuring RAACD goals. So within the RAACD implementation plan, the committee said this is what we want to achieve. And they pointed out, or they measured, or not measured, what am I trying to say? They stated what the goals were going to be. So for all child deaths, they wanted a decrease in 10 to 20%. And in terms of those deaths resulting from perinatal conditions, decreased by at least 23%. So these goals are all related to the county. They're not specifically related to your neighborhood, but it's basically the collective goals that we'd like to see by the year 2020. And so what this document does is it really puts those percentages into concrete numbers. So when we go and measure several years out, we'll be able to see what that target is. So the next slides are a series of trend lines. And again, this is using those 3-year rolling averages, but it lets you see sort of historically, have the deaths been going up or have they been going down? So in this slide, what you can see is the orange line, which represents African American children, the black line, which represents all children, and then all other children from all other ethnicities. The other piece about this is that it's a rate. And so why rates are really important is because it allows us to compare sort of the frequency of an event across different populations. So our African American population, it's 11% of the whole population. And so if you just look at the raw numbers, you can't really see if child deaths are occurring more frequently within a smaller population. And so what we do is we look at deaths per 100,000 children. And so what we see in 2014 is that there were 83.8 child deaths to the African American child population. If you look to the right, there's a shaded box called RAACD goals, and underneath it 2020. So that's where we want to get to. And then what we went ahead and did is calculate what a 10 to 20% reduction would look like. And then that would be 67 to 75 deaths per population. So are there any questions about this and this type of graph?
And a reminder to type them in, since we can't hear you.
Oh, yeah.
And go to.
What do we do? She said it would have a white.
So, doesn't look like there are currently any questions.
Okay.
If you have a question and we're not catching it, you can raise your hand like you had before, so that we can make sure to check it.
Mm-hmm. So each of the causes of death has a corresponding chart. And so it's a trend line. And so this is perinatal conditions. And as you can see, perinatal deaths due to perinatal conditions peaked in 2011 and has been slowly decreasing. In 2014, we're at 3.2. And when we're looking at perinatal conditions and sleep-related deaths, we're basically looking at babies. And so we look at 1,000 births. And so the rate is 3.2, and we're trying to get to 2.5. And I want you to pay attention to the distance between the lines. So the African American, again, are the orange, and then the gray is all other. And then when we talk about disproportionality, I want you to remember this distinction here. So I'm going to go pretty rapidly through this. Again, in infant sleep-related, we have a question. And the question means we go like this in Q&A. For the last slide, does it mean that 3.2 per 1,000 African American children are dying? So let's go back to that last one, slide for perinatal. I think it's this one. Minimize it, okay. And we'll go back. So yes, it means that for every 1,000 births that happened in Sacramento County,
Babies.
Thank you. So 3.2 babies died, and so roughly 2,000 African American babies are born a year, and so that would mean that on average it would be about 6 babies die from perinatal death. Let me see, did that answer your question? Go poke up here again. Dominique, did that answer your question? So, okay. We haven't heard from Dominique, but let's see. We'll move right along. So, if we can move this. So infant sleep-related, 2008, 2.8 per 1,000 births, and the goal is to get to 1.6, 33. Thank you, 1.9. And then again, I think somebody poked. I need a mouse. Oh, thank you. And then we'll go here again. Can homicides, again, you see how the orange line, how there's a big dip in 2011, 2012, and then it spiked again in 2013. And this is largely due to the small numbers, thankfully, of can homicides, but you see more of a variation when there are smaller numbers. And so the goal is to reducing that rate down to 5.4, which would be a 25% reduction. And then third-party homicide, again, there was a dip in 2011, and it's slowly rising. And 2014, 6.7 deaths per 100,000 children, and we want to reduce that to 3.5 at least, which would be a 48% reduction. So those are the 5-year county trend lines for the 4 main causes of death and then overall. And then the next section we're going to talk about is the community indicators. So the front of the report, we deal with the 4 main causes of death and the goals. And then we move into community indicators. And community indicators, as I mentioned before, are indicators that are related to the causes of death. They're not necessarily a precursor, but they give us sort of a one step out, sort of a bigger picture of what's going on in the communities. And let me tell you a couple of the reasons why we chose these different indicators. There's certainly other indicators out there, but we had a couple of different criteria. So one was to be able to get them on a consistent basis. And then the other was to make sure that we can look at the data specifically through the by African American population and by zip code, because there are a lot of different data sources that summarize the county, but we really wanted to take that neighborhood look and be able to break it down by zip codes. So that was how we ended up with a lot of these indicators, and also through the evaluation committee. Question. Came up with a lot of them. Yep, we have another question.
And get the actual number so we can better explain to our community.
Okay. So the question is, how do we take these rates, for example, the 3.2 per 1,000, and get the actual number so we can better explain it to our community? So instead of 3.2 per 1,000, we can say 6. This is a great question, and it brings up something that I failed to mention. So when we're dealing with death data, I know a lot of the CIOs wanted to know specifically how many babies and how many children in their neighborhoods died. And we're limited when we talk about data by being able to share some of that data. So if it's below 10, there's a confidentiality aspect to that. And so one of the reasons that we did not give you the death data by zip code is that the county and the CDRT would not release that to us. And so I know that's frustrating because you want to know, so who are your people and how are they specifically affected, but we don't actually have that data. Am I answering that?
Oh, I think they want to know the actual number, just what 3.2 equals. However, I think it might help when we get to the disproportionality, and then they can just say,
okay.
Yeah, so maybe we can table that question.
Okay, so Dominique, we're going to table that question, and then you let us know if we, this is very strange talking to just a microphone, no feedback, but let us know when we talk about disproportionality if we've answered it. Okay, we're going to move on. So this table here, what it does is it shows.
Another question.
Oh, another question. I might just wait.
Okay.
Okay. That's just a little distracting.
Yeah, you could probably wait and take questions at periodic intervals.
Yeah. Okay.
Let's go ahead and do that. So with the community indicators, what we've just done here is just shown sort of how these different indicators line up to the different 4 causes of death. So what we've done here is we've included one of the indicators, and I wanted to walk you through sort of how we presented this data. So this indicator is children living below 100% of poverty. And so the federal government has actually defined poverty. And let me tell you what that rate is. For a family of 4, in 2014, it was an annual income of $23,850. So a lot of times the poverty line has been criticized because it is so low. I mean, that is very low. But nevertheless, it's a common indicator used to describe a population. So what you'll see here is the first set of data is Sacramento County. So we wanted to give you a comparison. Again, the orange being the African American population and the gray being the all others. So what you see here is that 42% of, so this is children living in poverty, so children whose household is under the poverty line. So 42% of all our children in Sacramento are living below the poverty line. And those are the African American children. And that's in a comparison to 23% of all other children. The next line is the RAACD focus area. And when we say focus area, what we mean is all these neighborhoods, all the zip codes that encompass the 7 neighborhoods. So it's just those focused zip codes. What we see is that 50% of African American children are living in poverty and 36 all others. And then again, then we broke it up by the specific neighborhood. So Arden Arcade, 74% of all the children in Arden Arcade are living in households that are below poverty, and that is compared to, oops, sorry about that, 27%. So when you look through the community indicator report, you'll see all these indicators broken down by the county, by the RAACD focus area, and by the neighborhoods. Where we didn't have data, so I think there are some different indicators that we thought were really important, but we didn't have it by zip code, we still included it. And then you'll see what are some of the other oddities that came out when we did that.
Like the schools, the schools aren't by
zip code, yeah.
They're not by neighborhood, they're by school district. The truancy data.
In the alcohol.
Alcohol and drug, we couldn't get by neighborhood, and juvenile felony arrests, we couldn't get by neighborhood.
But we felt that those were critical in talking about third-party homicide. So we did include those. So the last bit that we're going to talk about is disproportionality, and this is the whole impetus behind this initiative, is talking about not just the number of deaths, but how that relates to the rest of the population, and how African American children are dying at much higher rates than all other. And we left the text in here because I think it might help explain sort of why we use the rates. And again, the rates are used so we can compare them across different ethnicities and subpopulations. So in 2014, the 3-year rolling average for the death rate was 83.8 for African American children, meaning that out of 100,000 children, 83.8 passed away. And in comparison, it was 31 children for all other children from all other ethnicities. So the ratio, so we look at 83, almost 84 deaths to the 31 deaths, translates to a disproportionality in African American child deaths at a rate of 2.7 times all other racial groups. So if you can see what we do with the different rates is it's basically we divide 83.8 by 31.4, and that gives us the disproportionality. And so what we did is we did this with all the different, all the 4 main causes of death. And so the disproportionality for all child deaths is 2.3 times African American children die in Sacramento County. Thank you, 2.7. I'm having a translation problem on from the screen. 2.7 African American children died 2.7 times all other racial groups. And as you can see, this varies by the different causes of death. So for perinatal conditions, African American babies die almost twice as much as all other groups. Infant sleep-related, almost 5 times. Canned homicide, almost 9 times. And third-party homicide, almost 4 times the rate. And so that's when we talk about disproportionality. That might be a little more wonky than you wanted to get into, but I think it's important to understand sort of where those numbers come from.
Stop her.
Yeah.
Yeah, that's what she's trying
I'm
to get
trying
to. It's not opening.
Move it over away.
Okay.
Oh,
Yeah.
oh, there it works. Oh,
Let me see here.
okay. Scroll. Yeah, scroll down.
Okay.
Can you read?
Yes, thank
Okay.
you. Can you re-explain the acronym for CAN homicide? So CAN means child abuse and neglect homicide, and how those deaths are identified is through the Child Death Review Team, and so they look at all the context, all the contextual factors related around the death to determine if it was related to, so CAN homicide is, or child abuse and neglect homicide is the death of a child due to a caretaker. So that would be a mother or father or family member. A third party homicide would be a death from someone that the child doesn't know. It would be a stranger or something like that. And that is the distinction between a CAN homicide and a third party homicide. Did that answer your question? The person who,
Okay. Anonymous.
cool, okay.
And then how about-
Is there someone else? Oh, yes, thank you. I love the feedback.
How about Dominique? Did the disproportionality?
Oh, yeah, Dominique, did that address the disproportionality? And we'll talk, there's another slide with disproportionality. Let's see. Okay, we'll keep going because I don't want to. Let's go to this. So what we did as well, in addition to looking at the disproportionality between the four main causes of death, we also looked at the other indicators that we collected, the community indicators, to look and see how this disproportionality basically is a ripple effect into other issues. So juvenile felony arrest, almost African-American juveniles are arrested for a felony almost 8 times more than any other racial group. Foster care, children are placed into foster care 4 times the rate of any other racial group. Child abuse allegations are made almost 4 times the rate of other racial groups, and so on. And so I think it's important when we start, I should say you all are starting to think about how you are going to address these 4 causes of death in your neighborhood. You can look to these other issues where the disproportionality shows up and sort of begs more questions and more answers from you all about how that's going to be addressed. Did someone else pop in a question, or am I? Leslie was going to say something? Oh, thanks, Les. Okay, so let's see.
Oh, see, I know I was wondering if you should address the educational attainment.
Oh, okay.
There was a, remember the?
Yes. So the last figure is looking at bachelor's degrees. And what it shows is that it's less than 1. So it shows that African-American youth are getting a bachelor's degree at a lower percent or a lower rate than other groups. And I think this is really interesting because actually African-American youth graduate from high school at a higher rate than other groups, but they are getting a bachelor's degree or higher at a lower rate. And so I think there's so many questions around all of these indicators. I think they're really, they're sort of, I see them as a starting place. And when we were presenting to the steering committee, you know, a lot of people said, this is not information that's new to us. We know this. And so I would not even attempt to think that I'm telling you something about your neighborhoods that you don't already know. But I think one of the functions of this report is that we all have the same language and we all have the same numbers. And I think it can be really powerful when as a united voice, we're all talking about this disproportionality in the same way. So,
I'm gonna check the chat button too.
okay, we're going to check the chat button. And There's nobody checking, so we're good.
Okay.
So the next steps for 2018. So in 2018, the community indicator report is going to be updated. And so as you know, it's the baseline year 2014. And I'm sure you all are saying, 2014, that was forever ago. But one of the reasons we really wanted to present a baseline. The other issue with data is that there's always a time lag. And so it takes a year or two to actually get caught up. So that will happen next spring. As well, in the fall, we are busy putting together a crime and neighborhood safety data dashboard. Kendra got together the sheriff, the sheriff and the police and probation, and so they have been collaborating with us to get together some information that will inform your neighborhoods and see what's going on. In the spring, there's going to be another data dashboard, but that hasn't been decided yet. But if you all have something that you really want to see, you should let Tracy know and Kendra know, and we'll see what we can do. What did I forget?
So
I always forget.
yeah,
I was wondering, can we unmute them? Can we unmute them and then have a discussion? Do you know?
Okay, first let's have Leslie was going to say something.
Right. So I was going to go back to Dominique's question because it sounded like it was a question about numbers and the ability to actually talk about how many, right? Because of the example was the perinatal conditions, and if it's 3.2 out of 1,000 births, there's 2,000 African Americans, then is it 6? And I think, I guess the question is there a source for just the numbers? Recognizing that it's not available at the neighborhood level, is there a place for our CIL partners to go where they can at least get the raw numbers?
I agree. And I think that, in fact, that this next question actually is getting into that too.
Yeah.
So the next question is one of the.
Okay. And I was going to say, I think the CDRT report is probably where they would get the child death review team. And they are coming out with their 2015 shortly. So that would be the most up to date. But yeah, I think that I agree that when you talk about rates and numbers per 100,000, it just really sort of depersonalizes it, and it makes it a very abstract thing when we're really talking about, losing children. And so the next question that was submitted was for folks like me in the public eye, how do we get bullet point talking points? The data is amazing, but processing it to develop ways of communication can be difficult without clear bullet point, layman talking points. And I think that's a great question. And Kendra, did you want to?
Yeah, I think that yes. So one thing that you should know is that in all of the buckets of communication materials that Madeline sent out with the teams at the last Thursday from Child Purpose Institute, that the fact sheets actually have those bullet points and those terms and the communication pieces for multiple audiences, whether it's, politicians, community-based, faith-based, young people, parents. Those fact sheets should really be your kind of your beacon of talking points and how to go in each one of these areas. I also encourage you all to make your own talking points. There's so many different personal stories that really help bring and bridge some of the gaps of understanding for folks. So what really does child abuse and neglect mean? You might have to use a story that goes along with those numbers that really help people, oh, I understand that now. What does third-party homicide mean? You've got to use a story that goes along with that number to help kind of unpack some of those pieces so that you're right, that it goes down into this very authentic, layman's terms, but really just so that people can grasp it, understand it, and we can build with each other.
Yeah, and I'd like to say too, I think as a layperson, you can say, African American babies are dying at 3 times the rate of all others, and you can leave it at that. But this document is supposed to sort of have all those caveats, you know, it's per 100,000, it's from this data, it's a rolling average. And I don't think the message necessarily needs to include all that kind of, that context, because we have it here in the document. And so you can always say, well, look at the community indicator profile, right? Because otherwise you don't want to get all, I would never give sort of a general public this presentation, because they don't care. Really, what you really need to know is that Black babies are dying at a higher rate than other children, and we need to do something about it. So I think that, yeah, always have to do something about it. So, but use this document as sort of your reference, and then you can talk about, I think you can talk about it in really simple terms that it's very intuitive for people to understand. I keep looking at the screen and talking to it because I don't have anyone to talk to.
Oh, good. There's another question.
Yeah. So the other question was, can you tell us on how the data was gathered? Are all the numbers produced by the Child Death Review team? So yeah, it's a great question, and that is true. They are all the data is from the Child Death Review.
All the death data.
The death data, thank you. So the death data is, and that one of the reasons that we ultimately went back to that is that the Blue Ribbon Commission report that was the impetus for the whole initiative used the CDRT data. If you want to know where all the other data was gathered from, if you look in the report, it is noted in the very back.
At the bottom of each page.
Yeah, the bottom of each page. So some of it comes from the census data. A lot of it comes from the census data, the American Community Survey. And then some of the other was the birth data actually came from
The Public Health Department.
Public Health Department. And so we had to sort of poke around to get a lot of this data, but it's all cited here. And then if you go, the other data, the neighborhood profile has all the data sources actually in the back. So does that give you a good sense of where the data came from? Or would you like a little bit more explanation for that? Because I'm happy to go into more. Okay, great. So any other questions or any sort of comments about how you can use this, how you can't use it, what you would like to see in the updated version?
Are you interested in seeing if we can unmute their end so they can have a
Oh, sure. Is there a way to unmute their end so we can have a conversation, or is that?
We can try.
Okay. I think there's another question.
Somebody asked if there's any community events happening soon. The website currently has a glitch, and that's why the events aren't posting. So I promise you there are a lot of events happening, and we are working very hard to try to fix that glitch. It's very frustrating. So I understand that frustration as well. But please continue to look at the Wednesday weekly blast too for that information. And we'll continue to communicate with the CIL leads and hope that they can push out stuff to their partners as well. I'm going to try to see.
Better warn everyone.
So we're going to try and unmute you all. So just a little fair warning, the audio. Maybe we can't do that. Computer audio.
Yeah, I'm sorry.
We just wanted it to be a little bit more interactive, but we can check and see if on the Q&A.
I do not know.
Okay.
I'm sorry.
No worries.
So unfortunately, we're not able to have an audio conversation, but if anybody has any additional questions, please feel free to do it by chat. I'd also like to mention that the community indicator report is up on the BCLC website now on the impact page. So you can find it there if you wanted to share it with folks. Everybody who registered for this webinar should have also received it digitally in your email, or when the registration link was sent out, it was also sent. So we hope that that's easy to to share and to find online. And if you have, if you need to be able to find it, just let us know. And you can always send questions to the RAACD email, and we can forward them to LPC associates here to help get the right answer to you if you think of something after the fact or when you're working through the information and something comes up for you.
All right.
All right.
It looks like there are, oh, one more, somebody just popped up.
Okay. We love questions, so.
And thank you for bearing with us on their technology as we're learning it.
Oh, you could talk about that. So the question is there a way or efforts being established to reach out to hospitals to get those parents returning to our neighborhoods info about BCLC? I know there is an initiative to do with the safe sleep, and I don't know if it's specifically around the BCLC.
I'll answer it unless Kendra wants to.
Okay.
A few of our steering committee members have been a part of a safe sleep working group outside of the steering committee, and kind of coordinated with First Five and CAPC and others. And so something that they did in the very, like one of the beginning of the initiative before the CILs really got going was they started this program to train all of the nurses to use the same curriculum to, when a mom has a baby, they ask a few questions about their sleeping habits and how they will sleep their baby to make sure that the family has a safe place to sleep their baby. And they are, then if they don't have that, then they're offered a pack and play to take home with them. So much like with the car seats where they're, you must have a car seat to leave the baby, they're also trying to reach those families at birth. They don't mention the Black Child Legacy Campaign by name, and the literature is all of the Alone on the Back in the Crib literature that supports infant safe sleep. So that's kind of how it works, but they're not necessarily like giving them information on the CILs or that kind of thing. And we can explore what kind of partnerships that looks like, especially with those steering committees members who are representing health systems and who are kind of more of our direct access. We've had good relationship with a number of pediatricians and others who have joined us in that work, especially we've even had some folks who were on the Glory planning team and things like that who were, pediatricians. And so we have different kind of relationships that we're working to get that information out. But as far as making sure babies have a safe place to sleep, there are a number of efforts to do that in the hospital. And somebody also just asked where you can get a copy or access to all the slides that we presented today. So we're recording this webinar, and we will put the recording and the slides that go with it in kind of a package online. And we will hopefully do that soon. But we do ask that if you share this information, that you make sure people have a copy of the community indicators report, so that that's their first entry point to this information, so they can kind of read through it first.
Any other questions out there?
And again, you can send it to RAACD at
shscenter.org, RAACD at shscenter.org.
Yeah, and if you think of something, or if you get field questions from your community members and you don't know the answer, we might know the answer. I'm not saying we will, but definitely contact Tracy, and she will we'll get you an answer as best as we can.
Well, I do just want to say, I know that we're closing down the call, but I just want to give a big shout out to Shannon and to Tracy and to Leslie and to Madeline. But to you, Shannon, for your hard work on this over the past couple of years, both in volunteer capacity and as the lead. on the LPC team data hub. We're looking forward to moving into the next iteration, but really just value working your team member attitude is really having an uplift for the whole project. So thank you.
Oh, thank you.
All right, thank you, everybody, and we'll see you soon.
Thank you.